All right. Well, we've got kind of an off-axis talk today. We've got the illustrious Chris Brown. Chris is a Scripps Clinic trained interventional cardiologist who recently joined the staff of Providence Swedish in Seattle. He's been there for just coming up on a year now, where he directs the complex coronary intervention program. And we thought it'd be helpful for Chris to talk a little bit about the process of building a complex PCI program, transitioning from fellowship to being a full-time attending interventional cardiologist, and just to talk a little bit about the importance of mentorship and how to grow your program. So, Chris, without further ado, take it away, my friend.
Oh, thanks, Joe, and thanks, Aidan, and thank you guys for building this platform for us to sort of connect as interventionalists and for as fellows and as learners and everything, because it's really sort of taken me to a different part of my career and a new place in my skill set by having access to all these interventionalists and everybody to bounce things off of and discuss and see how different people are doing things. So I think it's a huge value add to the community at large for interventional. So I'm just going to go through like maybe 2 or 3 slides here. I hope you guys can sort of tell me what you think about what I say, because it's not necessarily right or correct. It's just sort of the way that I thought about it when I started this program and this journey, and it's sort of the steps that I've taken along the way, including the ones that I wish I would have taken maybe sooner, but ultimately got to, I guess you could say. I think the biggest thing, if you're a fellow or a practicing interventionalist, if you're looking to change sort of the kind of practice that you're in or you're going to move, is really being as selective with your job search as you can be. But really what that means is being really upfront with wherever you're going, with what you're trying to do. So at all the places that I interviewed, I was very upfront about what I was looking for with regard to, directing or being a big part of a complex PCI CTO program. I was very upfront about my desire to do endovascular work, and then my sort of lack of desire, if you will, to do necessarily structural interventions, because that wasn't really my thing. But I think you have to be really upfront. I think a lot of times when you're a fellow, you feel so like, oh, I got to get a job, or I want to live in this certain place. And you kind of trap yourself with, oh, well, it kind of has what I want, but it doesn't really have what I want, but I'll do it anyway. Or, the money's really good or whatever it might be. But I think you're going to be a lot happier if you're just very upfront with them about what you want, because you'd be surprised at how much they're willing to tailor to or are interested in any of the skills that you have, that you can bring to them that they haven't even thought of or don't know, that they wouldn't realize that, there's a need or a huge market for X, Y, or Z thing to be done, and nobody's doing it wherever they are. So I think that was a big thing for me that really helped me get to sort of the right place, if you will. I think a big part of how you figure out where or how you get to where you're going to go is with mentorship. I don't know how much other people interact with their mentors or the people that train them with regard to finding their jobs. But, I think my thing was, then we've all, been with Paul Tierstein, and the things that I discussed with him were more along the lines of, does he think that this place, in how it's been described to me and the data that I can sort of find from other sources, does it sound like a good opportunity to him as well? Because it sounds like a good opportunity to me, but he can, from a really objective place, and somebody who's been in the field for, 25, no, more than that now, 35 years, can really tell you, oh, this is a red flag, or, oh no, this is the opportunity. And I talk with him, I talk with Tim Henry, I talk with Mike Wyman, Dohad, Bill, I talk with everybody about this, trying to figure out whether the job suited me or not. And I think that the mentorship also helps you define if there are going to be little or big obstacles, and if you will be able to or will need to try to overcome them when you start. So there might be 1 or 2 little obstacles that they identify. That doesn't mean that it's not a good job for you, but it is a good opportunity to ask anybody that whether that's a junior faculty somewhere else, longtime faculty somewhere, your current mentor or person who's training you, how do you overcome that type of obstacle? Because I guarantee you, at least some of those people have dealt with that exact thing, and they can really help you, get forward with that. And I think in the broader sense, the mentorship, as you're looking for a job, just provides you an outlet for just like real honest advice, because they're as invested in you doing well as you are essentially, but they don't have any of the sort of baggage that you have. They don't need you to get paid a lot or not get paid a lot. They don't need you to live in a certain city or not live in a certain city. They can just objectively say, look, that's a terrible job. That's a great job. Or that job's pretty good, but it has this and this, and you might want to rethink, or you might really like it, but you need to be aware of that. And I think that that's important. So I don't think I could have done it without that sort of mentorship. I don't know what you guys use or
I
who you
totally
talk
agree.
to, but
I totally agree. And I think the problem that most interventional cardiology fellows have coming out of fellowship is when they go to look for jobs, the first thing they always ask, because we've interviewed a bunch of people, there's this, what's my volume going to be? Right. And so they want to go to a hospital and they're like, well, am I going to do 100 PCIs a year? Am I going to do 300 PCIs a year? And I think that's the wrong question to ask. The right question should be, how much volume can I generate? Right.
yeah,
Because there's so many people that go to programs, especially in California and these saturated markets, and they want to be handed over 250 PCIs a year, and they want to have X amount of CTOs, and I think that's unrealistic in terms of your expectations. My first job that I took out of fellowship was at Kaiser, because that was the opportunity I had that gave me the most volume out of the gate. It was a huge mistake. I lasted 9 months. I'm not a Kaiser doc, and that's okay, but that was a mistake that I made that I don't want other people to make. Is don't come out of fellowship and pick the first job you think that's going to give you huge volume. Pick the job that has the most upside and gives you the most resources to support the goals that you have. And I think that's something you did at Swedish that was really smart. Is even if you said out of the gates, I'm going to have 100, 150 PCIs, which is great, you've built it into something bigger because there was opportunity there. So I think that's important. And the second thing I'll say is just it's about the people too. That's the other thing people don't ask about. They want to know the salary. They want to know, what's the call like? What's my volume going to be? Get a sense of the people you're going to work with. Because if you go into a group that's toxic or has one or two haters or people that just aren't going to support you,
yeah.
that's a horrible decision. And so I think just to kind of double down on what you said, I think that's super important. Rain, what do you think, boss?
No, I agree. I think it's all about the opportunity. Some of these, when I came out, we didn't even have a TAVR program or a MitraClip program, but a lot of patients here that were not getting treated. So you could definitely see, the opportunity there, and it's worked out great.
Well,
yeah,
dude,
I mean, I think
remember when you were looking in Orange County, you actually just looked at the population of people and the fact that there was like one structural heart program there, and you saw that opportunity in Orange County and you really capitalized on it. What remind me of the numbers? Like how many people are in Orange County?
There's like 4 million people in Orange County, which is, the same size as San Diego County. It just happens a lot of people go north, they go south, but the people are here, and everyone, the need is here. So I think that's, looking at what the community is like is, just because there's nobody doing, a program there, if there's a big opportunity, you can totally create it.
I think that's a really good point, because, when I interviewed here, I think that two things happened. One was I was really upfront about what I was looking for, and that sort of allowed me to smoke out if there was going to be any people that were haters about what I was going to be doing. And essentially they were all just very, the appearance was, oh man, we would love it if somebody would come and do that. And that ultimately ended up being what it was. I did go on other interviews where you could tell that one or two people really thought that was a good idea, but a couple of other people maybe weren't so sold on that. And those ultimately would have been bad opportunities. And in fact, one of the things that the director here said when I interviewed was, I can't guarantee you X, Y, or Z number of procedures, but this is the size of the system. And so you do with that what you want with regard to complex PCI and CTO, because there's not somebody doing it. So if you think that this size of the system will allow you to build, what you want, then that's sort of what we're offering you. And I had to, it's a little bit hard at first because there were other jobs that were sort of quote unquote guaranteeing me more cases, but they certainly would have never been the volume that I was able to sort of acquire here, because the system is so much bigger, but nobody was really wanting to or trying to concentrate that effort towards CTOs and complex PCI for the system. So I really think that's a good point, Joe, is you can't say, oh, I'm going to take the job that's guaranteeing me 250 PCIs. One, I don't know how they can guarantee you anything. But two, even if they can only guarantee you 50 PCIs, if they have 4 million people, like Aidan said, well, that means that there's 450 other PCIs that you could go and find. You just got to go find them, because there's a lot of people, and there's a lot of people that need a lot of things done. There's a lot of people that need a MitraClip, a tricuspid clip, a TAVR, a Watchman, a complex PCI, a CTO, that are just not getting those things done because either the referring system is unaware of the interventions even existing, or they just don't even know where to go with it because there hasn't been somebody who's been a champion of it. So I think you can't focus on what is the current volume. It's more, well, what could it be for me? I think the other thing that is big that Joe said, which is, you know, got to make sure that there's nobody that's going to be actively against what you're trying to do. Somebody that's not interested or doesn't think that what is being brought in is a good idea. And this is particularly true in complex PCI. Is finding good support from your partners. And that's not just your interventional partners or the general cardiologist who may be referring you stuff, but it does include them. But it's really support from CT surgery in the sense that, you know, Joe told me this very early on, as you know, as a great piece of advice. And I think this really is resounding in the sense that if you see the 3-vessel diabetic CABG patient, it looks like, oh man, I could just fix all that with PCI, whatever it might be. It's like, no, let them see a surgeon, be a good member of the heart team, because what's going to come back to you is 7 surgical turndowns or something. I mean, it'll literally come back to you multiple fold if you're a good participant in being a part of the heart team. Now, of course, you need good CT surgeons who want to be partners with you. But I generally, in my experience interacting with CT surgeons, if you want to be partners with them, they want to be partners with you. There's lots of reasons why they don't want to do a bypass surgery on somebody who has horribly calcified aorta or whatever it might be. They've already had a stroke, whatever, that they really don't want to have to do because it's very high risk for them. And they would love for somebody who can say, no, I can fix that with stents and get a great outcome and essentially have the exact same durability as a surgery. And, you know, they really want that too. And they want to be on a team with you if you can be. So I think that was one of the best pieces of advice somebody gave me. And Joe gave that to me early on before I even started my job. And my other mentors have talked about this, you know, Bill Lombardi in particular has sort of extensively said to fellows in his teachings, you know, look, there's plenty of cases. There's lots of people that need fixed. Never worry about whether you're going to do a surgery or a PCI. Whatever's best for the patient is best for the patient.
Yeah. So true. The last thing you want to do is come out and, you know, be antagonistic towards your surgeons. I mean, I have a great relationship with my surgeons. We rarely are on a different page. Almost always it's, look, there's plenty of work to go around. And if you get on a good side with them, for me, I get tons of I'm more structural, but I get tons of referrals from them for patients that, you know, I may not have even seen the patient. They just don't think they're a good surgical candidate. So, you know, they'll call me, I'll coordinate with referring, and it's been a huge help. And, you know, I see your second point there too, advanced heart failure. You know, there's a lot of patients that, you know, end up with, you know, in the advanced heart failure team, but, you know, educating them and, you know, letting them know what you have to offer and how that can benefit their patients could be a great source of referrals.
Yeah. No, it really is.
I think, you know, the first thing I did when I moved to Boise from San Francisco is I, you know, bought my surgeons a bottle of scotch, took them out to dinner, and we set up the program for complex PCI, and it's helped with structural too, is anytime you have a patient that's referred for you for CABG, if they are too high risk and you cannot do them, I will take them on my service. I will take them over as my patient, and I'll either fix them or I'll put them on palliative care or put them on medical therapy and follow up with them. So they want to take that responsibility off their shoulders. You know, when they get referred a patient for a CABG, if they're too high risk, and these patients, these are scrutinized, right? I mean, they have public reporting. I think that's the most important thing you can do to really build your complex PCI program, because the majority of your patients are going to come from surgical turndowns, and your surgeon has to trust you. They have to know that you're going to take over the care of that patient, that you're going to do a good job. You're going to manage the family. You're going to manage the referring physicians. And I cannot emphasize enough how important that relationship is. And it's going to pay huge dividends, not just for PCI, but for structural. And I'll tell you what, I go in the OR very frequently, and I observe my surgeons. When I refer them a patient, I go in the OR and I watch their cases, and I see how they're working. I see how they're collaborating with their team, and I learn a lot from them. And so I can't emphasize enough how important that relationship is, not just to grow your program, but to make you a better operator and to help you understand the nuances of all this stuff. So that's a really good point, Chris. And the same with advanced heart failure. Those folks, you know, they work their asses off getting these patients on goal-directed medical therapy and getting them options for advanced treatments. And that's another relationship that I can't overemphasize how important. So Chris, let's talk about a paradigm that I'd like to try to break, which is what everyone tells you when you come out of training, which is don't do hard cases for the first 6 months. And I think that's the worst advice you could ever give someone. So tell me your perspective on that and how you manage that false paradigm.
So I completely agree with you. I think that's terrible advice. And I'm sort of stealing again from Bill Lombardi and Mike Wyman and some of these guys who told me that that was terrible advice and not to listen to anybody who said that to me. But I think that there's a good point there where you say, look, do what you were trained to do. If you did 400 PCIs in your fellowship or 700 PCIs in your 2 years of fellowship and 150 or 200 of those were CTOs, how could you possibly be any better from a technical standpoint than when you just graduated? Now, I get that you might not be 100% confident compared to when there's somebody standing next to you or somebody sitting in the control room sort of monitoring you, if you will. But at the same time, it's very likely that you're going to be the most technically trained person wherever you go. It's unlikely that anybody else will have more technical training than you. And in that setting, you're also have to recognize that if you wait 6 months or a year to do something that's technically difficult again, you will have diminished your skills tremendously. Like, you have just polished what you are doing. You just finished off your last retrograde CTO and you graduated, and you are ready for that. Now, you might not be as fast at doing it or as facile. You might not have all the same equipment. And, something we can talk about in a minute is sort of how you manage your lab staff, because they may not be ready or used to some of these techniques or these procedures, but you are most prepared to do difficult things. And that's what somebody hired you for. So I think you have to be thoughtful about what cases you choose, in the sense that, yeah, you don't have to do every single case. You mentioned, Joe, look, I will take every surgical turn down and I will make sure they are taken care of appropriately. If they cannot be revascularized by me, I will send them to somebody who might be able to, or if everybody agrees that it's not possible, then we will provide excellent medical therapy and or palliative care, or whatever it's going to be. But it doesn't mean that you don't do hard things or the difficult things that you were trained to do for 6 months or a year, because everybody says that, because you want to have great outcomes. It's like, no, you want to have great outcomes regardless, but there are complications with doing difficult things, and you have to be prepared to manage that. And that's what your fellowship and your training was for. And that's why you help train your lab staff up when you get there, and you make them better at it, et cetera. But I really think that that's just horrible advice, because it keeps you away from a ton of patient contacts that you could have, and it takes you away from being able to show what you can do for patients. So your surgeons and your advanced heart failure colleagues and people know how you can help them. And it really makes your skills slowly diminish, because, you might be Michael Jordan, but look, if he doesn't pick up a basketball for a year, he doesn't shoot the same as when he was with the 96 Bulls. It's not the same thing. And, you're just not the same person. And I don't think you're the same person when you don't do interventions that are complex for 6 months or a year. It's just really not the same. So I think it's important to go out there and do what you were trained for and be thoughtful, but do hard things.
Chris, they did win 3 championships after he took a hiatus for baseball. I'm just going to.
Yeah, I know. He still probably played basketball every day, and he was absolutely terrible at baseball. So,
hey, so Chris, jump into your staff. I can tell you from the get-go, I was probably a little bit kind of hard on my staff, and coming out of like a center where coming out of Scripps, and it's like, that it's just a different thing when you come into your new hospital. So what'd you do for training, kind of getting yourself comfortable with the new lab?
We did a couple of things. I'm fortunate in that, the system, which Aidan, you work in the same global system as I do. The system is unique in that if anybody has ever used a certain piece of equipment, anybody else can also use that piece of equipment, which is kind of a unique thing. So the fact that there are other complex PCI operators in the global system that we work in allowed me to essentially make a list of equipment, which was not particularly excessive, because I think that you have to be somewhat thoughtful in how many microcatheters you really need, how many wires do you really need in your scheme, and that kind of stuff. But it allowed me to get the equipment that I knew well, that I was comfortable with, that I knew I needed to be successful. And then, I sort of recognized that one of my goals, and we'll get to goals, I think, in a little bit, but one of my goals was going to be, look, we got to be able to start doing the things that they haven't been doing here, but we're not going to do them as fast as we did them at a place like Scripps or Cedars or wherever. It's just the lab staff at places like Scripps, they do high-risk interventions in every room all day, 5 days a week. So they're prepared for that. And it's sort of, I don't want to call it routine, but it's more or less routine.
Yep.
You're going to have to help train your staff. And I think one of the things I did was I identified people that were interested in learning something new or being in a complex PCI room, and tried to get the cath lab leadership from the tech and the nursing standpoint to install those people in the cases because with the understanding that, look, we all want things to go well for the patients, and these people are interested. So these are the people that should probably be in the cases. And then I ultimately designated like a couple of them as like the lead people for complex PCI. So they started to learn all the equipment. And then when there was a gap or something in one of the other tech knowledge when they were in the case, and maybe there wasn't only the people that really wanted to be in complex PCI, there was still somebody there for that tech number 2 person to lean on and say, oh, well, what do we need for this case? And they say, oh, we already have it. We got the card out. We got the micro catheters. We got the externalization wire. We have whatever we need to achieve our goals. But it really is your responsibility, in my opinion, as the operator, to teach them, one, the way that you do it, but really in a bigger sense, the way that the algorithms work, because that can help them be as predictive as anything. I mean, Mike Wyman has a really famous tech who went into the industry, but his tech was as good as any CTO operator, at least from like the algorithm standpoint, because he'd been in so many cases and he knew so much about the algorithm that he can hand you the piece of equipment that you wanted before you even asked for it. I mean, he knew where you were going, right? Your microcatheter wouldn't go. He'd hand you a turnpike spiral. Your, wire across gear won't follow. He'd call for whatever was in the top of your algorithm for that, whether that was free wire rota, laser on the cap, whatever it might be. He knew for Mike what Mike was going to do next. And so Mike was able to focus on what he was doing instead of having to constantly bark or ask for things or have people go look for stuff or whatever it was. So I think it's your responsibility to train them to be as good at helping you help the patient as they can be. And I think that you can really identify people who are interested in that, because a lot of people are in the cath lab that you're going to go to and they haven't done a lot of complex stuff maybe for a long time, but that might also mean that they're really interested in learning new things, and they would think that this could, change their job habits and make them feel more fulfilled in whatever that might be. Or maybe they really are interested in structural heart disease, and that, you're bringing that somewhere, and they have seen all these people not get appropriate care for TAVR or mitral valve disease or whatever it is, and this is something that you're bringing to the patients, because in the end, all the other people in the room with you, they're there to help the patient too. It's not just the physician. Sometimes it gets a little bit blurry because the only person who went to quote unquote medical school is the physician, but all those other people chose this job because they want to help people too. I mean, they work in healthcare. They define themselves as working in healthcare. And that's really sometimes we do, but we forget about it to a certain degree. So that's sort of my take on how to do it. Am I perfect at it? No, I'm going to be better at it. Absolutely. And I think that's all you can do,
Yeah, dude, I echo that. And I think I use that as motivation, not just for cath lab staff, but for administrators too. Like whenever you're encountering an obstacle, if you bring it back to patient care, it really pays huge dividends. So like if you're trying to add on, 5 TAVRs every Wednesday instead of 3, you use the excuse that like people die waiting for TAVR, right? Like we're doing this for patient care. You're going to be here till 4 o'clock as opposed to 1 o'clock. Because if these 2 patients don't get a TAVR, they're going to die potentially. And so that really motivates people. And the reason you're teaching your staff to put impellas in and manage complications is because at the end of the day, it makes a huge impact on patient care. And that really resonates. No one will ever push back if you use patient care and what's right for the patient as the excuse. So Chris, you've got a lot of really great insight into mentorship and having coaches and goals. And I think that's something that's lacking right now. People tend to finish their fellowship, and this is something Aidan and I have encountered a lot, but people finish their fellowship and they get convinced they have this finite set of skills and knowledge base that will never be expanded upon. And that this is what I learned at this institution, and this is how I do it. And I think that's a really scary, dogmatic way of approaching patient care. So I was hoping to hear about your thoughts on mentorship and having coaches and goals and stuff like that.
I think that that's really true. And I think the thing that sort of allowed this to be maybe easier for me than other people was I started my complex PCI journey at Cedars with Suhail Dohad and Mike Wyman. And then I moved to Scripps to be with Paul Tierstein. And being at Cedars, I then met Bill Lombardi and then began to interact with him as well. And so I had 4 separate complex PCI mentors, and then I had peripheral mentors in Curtis Dennis and other mentorship from Matt Price. But I sort of had these finite coaches, and what was great about it was Bill and Mike and Suhail and Tirstein, they all work inside of the hybrid algorithm, but they might not approach every case the exact same. One of them might just say, oh, we're going to ADR up front. I got this. And one of them might say, you know what, there's a huge septal. We might as well just go retrograde, up front. We'll waste no time. We'll be externalized and out so fast because it's so big that it won't even be any septal ischemia. And so they are working in the same algorithm, but with slightly different style, if you will. And that sort of opened my mind to, look, you can get a fixed set of skills from one place, and they might be really good skills, but you could be a lot better if you see how a handful of other people are also doing the same thing, in particular if they're very good at it. And the way for me to do that was to have several people that were my coaches, and they coach me in different ways about different things. Some of them are really more coaches about how we do PCI. Some of their coaches about how we do PCI plus some life stuff, and some of them are coaches about how we do PCI and the business side of how we work things. But I think having a coach is really the only way to get any better. I mean, the best example that Bill Lombardi and Aaron Grantham always give is that Tiger Woods has a golf coach. He's the best golfer that ever lived, inarguably so, demonstrably better than anybody else in the field for a decade, essentially, or longer. He still had a golf coach. He actually had multiple golf coaches, and his dad was his coach. I mean, he had all these people contributing to what he was doing. So even if I was the best operator in the world, which I'm by no means the greatest operator in the world, but if I was the greatest operator in the world, I would still be made better by having a coach. So that's the way I look at it, is this is not a knock on your skill set by having a coach. It's only you being better, which means you're better for the patients, you're better for your lab staff, you're better for, and these people have gone through things outside of the cath lab that they can coach you on. They have lived their entire life. They have been married. Some have been divorced. They have had kids. They've made mistakes. They've learned from those mistakes. They can help you not make those same mistakes. That's a huge thing, right? I mean, building a complex PCO program takes time. It takes work. It takes time away from your family. There are big mistakes you can make in doing this stuff, building a TAVR program, building whatever it might be, building this kind of business. You could make some serious mistakes from a life standpoint that they can help you avoid or help you navigate at a minimum. So I think that's one of the biggest things, is the coaches really, they make a huge difference, not just from a work standpoint or a PCI or whatever it is. They make a difference in your life in a way that I didn't really appreciate until I really started to use them for their sort of in the fullest way. And, I feel a little bit like, oh, I'm using them, they're giving me. But, I think about every time I taught a first year fellow something, and the sort of joy or the sort of the happiness I got from teaching them. And then you realize that, look, these people want to coach you as much as you want them to coach you, because it gives them a sense of fulfillment to help you. You know what I mean? It's not, it's not a one-way street. There's a two-way exchange you just don't completely recognize until you take a step back. And, the coaches have helped me with the second part of it, which is defining your goals. And for me, I define a goal every quarter, just because that works in the time frame that I can comprehend. And I feel like we can kind of get to those hurdles, if you will. You can define a goal as frequently or as infrequently. I mean, I wouldn't be too infrequent, but you can define a goal as frequently as you want. For myself, I define a goal for what I'm personally trying to do on my skill set, what I want the program to be able to do. Sometimes those are the same goal. I'll tell you my goal for the quarter, and at least in this quarter, they're the same. And then, you should be defining goals for your personal life as well. I didn't put that on here, but because that's not necessarily the context of this, but it is important. My goal for the quarter was to be faster. When I started here, I knew that my goal needed to be, we need to be able to successfully do retrograde PCIs. And because nobody had done them for a while, and I knew that wasn't going to be done in 90 minutes. I wasn't going to do a 90-minute skin-to-skin retrograde PTO. It was going to take 3.5 hours, because the equipment was new. There wasn't going to be somebody that was a step ahead of me with an RG3 and whatever I needed before I needed it. All that stuff wasn't going to be there, but I was going to be able to teach people. And so, in my third quarter, my goal became the same as what I wanted for the program, which was, I want the program to be more efficient in doing what we're doing. So I don't want to do 3 cases in a room of complex PCI in a day. I want to do 5. And the only way to do 5 is for them to all be less than 2 hours, right? And so that was our goal, and that became our goal as the program too. We want to be faster for this quarter, and that was the goal for the quarter. And we've been very successful, and because everybody was purposefully practicing being faster. So not only was I trying to be more thoughtful about not wasting time in the algorithm, not spending more than 5 minutes in each individual thing without switching and trying something else, but also the lab staff, they bought into that. And so what did they do? They built a cart full of CTO equipment and they roll it around. So there's nobody walking anywhere to get anything, right? That's time saved. There's nobody moving to go get me a Stingray. There's nobody going to get me an Estado. There's none of that. It's because you can't keep everything in every lab depending on how your stuff's set up. But that was their contribution to our efficiency, right? And even anesthesia got involved in that goal. I use a lot of anesthesia for CTOs because I think it really helps with patient comfort. And they got bought into that we'll take slaved off arterial lines. We don't need our own. We'll help manage the sedation with, no airway stuff. We'll just use minimal propofol, or we'll give moderate sedation unless the patient gets uncomfortable. They really added to the speed of the case too. So I think if you define your goal and the program's goals with all the people that are involved there, and allow them to be a participant in helping define the goal, because they might see something about the program that you don't, that actually could really help you. But if you do that, then you can really move what you're doing and your stuff forward so much faster than if you try and take on everything. And I think physicians spend a lot of time trying to take on all the aspects of everything because that's kind of how we think or something. It's like when you're an intern, you're going to write the note, you're going to take care of the patient, you're going to check the labs, you're going to be the first person to know X, Y, and Z. You're going to call CT and get the report. You're going to do all this stuff. And it's like, dude, there's a lot of people to help support you. Utilize them. If you were a really good business person, you are the CEO, you don't do a lot of the stuff. A lot of the best business people in the world, they're just experts at identifying the right people to help them achieve what they're trying to achieve. So I think that's important. And I would have never thought of these things or been able to try and do that stuff without having the coaches that I have who are very explicit about the idea that, look, these are mistakes we've made. This is a mistake I made. You shouldn't make this mistake. And this is what you should try and do. Give it a shot. If you don't like it, you don't like it. But you got to give it a go. And these things have worked out essentially perfectly in the sense that none of the advice people give me has been bad. None of it's turned out to not be good. I've modified it in ways that I see fit for myself, but it always has helped me. So, and I think the other thing, which is the top slide here, which I want you guys deserve a lot of credit for, is there's so much extra support now, in particular because of social media. And I'm not going to use the brand name of the other social media, but I think that's actually a pretty toxic place where people are just out looking to, like, quote unquote, get people. But I think what Murmur has provided in this really protected environment is a way for people to actually truly have a discussion about hard cases, things they are unsure about that they might otherwise, people don't want to ask for help. You should always ask for help. But, you can run cases by people who are experts, people who have done more basilicas than anybody else in the country and whatever it is you're trying to do. And you can get great advice. Sometimes it's differing advice, which is perfect because that shows you like things can be done in different ways and still get the same good outcome. And it's a safe space and a safe community for people to learn. In particular, fellows, they don't have to be posting. They can be. But at least if you're reading and you're seeing what all of these people are doing, there's no way you're not learning things that are bigger than just whatever institution you're in. So I really think that that's where Murmur, I started on Murmur when I was a fellow. Murmur, I think, really does that for everybody that really wants to participate in it.
Yeah. Hey, Chris, I have a question. So you have these coaches, right? So how do you, let's get a little more granular on that. Like, how do you use your coaches? Do you have a formal process?
I have different ways I use them differently, but mostly I do three things. Thing number one is if I see something that I think that, if I look at a case and I start asking myself, should I do X or should I do Y? If I start to like hem and haw between how I'm going to do something, I know that that's an opportunity to show one of them what I'm going to do and say, look, this is what I was going to do. This is the alternative, and see how close to that they agree with what I said. And I would say 75% of the time we're in agreement. I'll send it to one or two of them. They'll send it back. This is how I would do it too, blah, blah, blah. 25% of the time they say, no, you don't need X, Y, or Z. You could just do this. It'd be a lot faster for you or a lot easier. And I say, oh, wow, that is actually a really thoughtful strategy, and that could be something as simple as, no, there's just way too much calcium in the landing zone. You're never going to be able to ADR that. You can waste an hour trying to get that to work, or you could just go retrograde from the start. And that's not necessarily what the algorithm says to do, but they have this sort of, Kirsten calls it AI, where you've seen literally 20,000 PCIs or 10,000 PCIs. You have a sense that no, that's not going to work. You've done 1,000 or 2,000 CTOs. No, that's not going to work. You should just go retrograde. And hacking into that AI that they have is very useful. The other thing I do is, when we have complications, I'm very fortunate that I've had the opportunity to manage a lot of complications in my training, because that's what comes with sort of complex stuff. But if I have a complication, even if I fixed it, I will show them the complication and say, would you have fixed it this same way? Did I make a mistake putting a coil here? Should I put a little tiny plug? Or did I make a mistake putting a plug in a coil? Should I put a plug in a coil, or whatever it is, Or would you have done nothing? Would you have just let this be? Would you have tapped that dry and it's such a small wire exit that there's no reason for this? You would have just, tapped the pericardium and given reversal, and tomorrow everything would have been fine and there wouldn't have been a coil? These sorts of questions that, you don't know the right answer at the time. Nobody can know for sure. But again, you're hacking their AI. They might have put in 100 coils in the 5,000 CTOs they did. You've only put in, 10 coils. And they've done let's tap it dry and see if it stops. And they know the ones that don't stop and the ones that do. And it would be great if we could have quantified that and put it in some sort of actual thing that, they could look at your angiogram live and say, oh, that will continue to bleed. But you really don't know unless you're able to, give it to them. So that's one of the other things that I think you can do, is always demonstrate your complication. I mean, and it doesn't have to be, I use contemporaries as people that I ask questions to. I called Vamsi Krishna 3 days ago about a complex venous intervention. He is one of the best venous operators probably in the world. He does tons of venous interventions. This is a really appropriate venous intervention that really needed to be done, but it wasn't that easy. And I showed him it and I said, what do you think about this? And he said, oh, that's fine. Put in your other stent and you'll be good to go. And I said, okay, man, I really appreciate it. And this is on the fly, live, So I think you can really, it doesn't have to be somebody who's a lot older than you or anything like that. Your contemporaries have great advice, and they're not necessarily my coach because, that's just not the interaction that I have with them, but that doesn't mean that they can't actually be a coach. You just haven't quite defined it that way.
That's a great point. Yeah. I think Joe and I, we talk a lot about stuff, and, like my TAVR practice has really changed a lot since what we did in fellowship. You talk about needing to keep up with new skills and stuff, and talking to Joe and some other people how they approach things differently. It's been a game changer. So you can learn a lot. Your colleagues can be your coaches too, I think.
Yeah, absolutely. And for people who don't think, oh, coaching doesn't work, it's like, well, I'll give you this is a random paper. There's a bajillion papers out there. But this is some paper where they said, if we coach people or we don't coach people, can they essentially be a doctor in the UK somewhere? Will they pass some tests that they need to take? And you can see how overwhelming the mentored versus non-mentored trainees are. It's essentially 2 or 3-fold better pass rates for all the things that they're trying to participate in if they just have a mentor or don't. And so this is, there's no data for interventional cardiology, but this is the same idea, right? Just having a mentor or a coach is going to make you better. There's just no way that it can't, right? Even if they weren't better than you at whatever you're doing, they can still see outside flaws or things that you don't perceive. I think Jocko Willink is probably the best guy to read about. He was a former Navy SEAL, and he always points out in all of his books, all of his leadership training, that the way that he was the best leader was he was able to recognize early on in his leadership that by stepping back in any military situation, he could see all the pieces, which allowed him to ultimately help direct the general strategy of what they were doing. He wasn't busy micromanaging how they were going to flank somebody. He just knew that, look, you needed to flank somebody on the left in order for this breach team to be able to access whatever door they needed or whatever it was. And so the coach is somebody who is, they're a step back from whatever you're doing. They're not worried about the minutia of, you're onto your second wire in your wire installation, or my microcatheter won't cross, I need a turnpike spiral, or whatever it is. They're looking at it from a bigger picture standpoint. And that, I think, is probably the most meaningful thing that they add in sort of a case-to-case sort of help, if you will.
Yeah. No, I love it. I absolutely love it, man. This has been great, Chris. I appreciate it, bud. I think there's a lot of good tips.
Thank you for having me.
Yeah.
early practice, mid practice, late practice. I think the theme is identify mentors, identify colleagues you can lean on, rely on your CT surgeons to grow your program,
Yep.
and set goals for yourself. So this has been really good, man. I appreciate it.
Yeah, absolutely. Thank you guys again. I really appreciate it. And, you know, thank you guys for developing Murmur. It's been a really great place for me to learn and to have a community. And I think for a lot of other people, fellows alike, and, you know, everybody, I think, should be really appreciative and thankful for what you guys did, because I don't know how hard it was, but my guess is that it wasn't easy to build. And it's a great, safe environment to be an interventional. So thank you guys.
Yeah.
Awesome.
All right, Chris.
Cheers, guys.